progressive dysphagia, weight loss, and a left supraclavicular node.
There it is. 3 clues, 2 organs. And I think in a lot of cases, 1 missed opportunity.
That feels incredibly heavy right from the start. But I guess that's just the reality of what we're talking about today, isn't it?
It is. I mean, there's no way to sugarcoat it. When you see those 3 phrases together on a patient's chart, the story is, well, it's usually already in its final chapter.
So by the time a patient actually presents with that specific triad, you're saying the trouble swallowing, the weight just falling off, and then that lump you can feel just above the collarbone.
Yeah. By that point, the window for let's say, a simple cure has often closed. We aren't just talking about making a diagnosis at that point. We're really talking about trying to intercept a timeline that's been in motion for years, maybe even a decade.
And I think that's our mission for this deep dive. We are going to conduct a masterclass in upper GI oncology. We're going to dissect the anatomy. We're going to get into the weeds of the esophagus, the stomach, and the proximal small bowel.
Right. The duodenum and its neighbors.
Exactly. But the goal here isn't just to memorize a textbook for an exam, though I'm sure this will help anyone doing that. We're doing this to understand the logic of the enemy.
Know thine enemy.
Yeah.
It's, I think, the single best approach to oncology. It really is. If you just try to memorize every single tumor marker, every staging criteria in isolation, you will absolutely drown in data. It's impossible.
It's just a list of facts at that point.
A list of disconnected facts.
Yeah.
But if you understand the environment, the why the esophagus fails in a completely different way than the stomach does, then the pathology, it suddenly becomes predictable.
It becomes a pattern.
It becomes a pattern you can recognize, and hopefully you recognize it before it becomes a tragedy.
I really like that framing. We're shifting from just, rote memorization to true pattern recognition. So to do that, we have to start at the very top. The esophagus.
The tube.
The tube. And in my head, I've always just pictured it as, well, a simple tube, a pipe connecting the mouth to the stomach, almost like a gravity slide for your food.
And that's not wrong functionally, but biologically, it's so much more complex. You have to stop thinking of it as one long, uniform pipe. It's much better to see it as 2 completely distinct territories, almost like 2 different countries with a very, very strict border.
2 countries. Okay, so we're talking about the North and the South.
The North and the South, exactly. And the golden rule of esophageal cancer, the one thing you have to remember is this. Location dictates histology.
Location dictates histology. So where the cancer shows up tells you what kind of cancer it is.
Almost every time. In the upper 2/3, the north, let's call it the dominant malignancy, is squamous cell carcinoma, SCC. But as you cross that border, as you get into the lower third, the south, it shifts almost entirely to adenocarcinoma.
So why? Why the split? Is the actual tissue different in the top versus the bottom, or is this all about what the tissue is exposed to over a lifetime?
It's 100% about the exposure. It's all about the environment. Think about the upper throat and the upper esophagus. The lining there is what we call squamous epithelium.
Okay, what does that mean in simple terms?
They're flat cells. They're durable. They're actually very similar to the cells that make up your skin. And they're designed to handle friction. Rough food, a hot cup of coffee, that kind of thing. But what they're not designed for is a direct chemical assault.
A direct assault. So now we're talking about irritants coming from the outside, from what we consume.
Exactly. The classic vices, unfortunately. Smoking and alcohol. When you smoke, the carcinogens in the smoke coat those cells. When you drink high-proof alcohol, you are physically bathing that upper esophageal tissue in a solvent, in a carcinogen. It is a direct contact injury.
And over time, that constant irritation.
Over years, decades, that chronic irritation causes those squamous cells to mutate. And that's the pathway. That's why squamous cell carcinoma is, in a very traditional sense, the lifestyle cancer of the upper GI tract.
So if I see a patient who's been a heavy smoker for, say, 30 years, and they've got a lesion high up in their chest on a scan.
You should be betting the house on squamous cell. It's the safest bet you can possibly make.
Okay, but now, let's travel south. Let's go to that lower third of the esophagus. The enemy here, you're saying, isn't coming down from the mouth.
No, the enemy is coming up from below.
From the stomach.
Right. The stomach is, for all intents and purposes, a vat of hydrochloric acid. It's an incredibly hostile environment. But the stomach is built for it. It has this thick, specialized mucus lining to protect itself. The esophagus, on the other hand,
it's just got that skin-like stuff, the squamous cells.
Exactly. It has no defense against acid. So when you have GERD, gastroesophageal reflux disease, and that stomach acid constantly splashes up into the lower esophagus, it's not just heartburn. It's a literal chemical burn.
The burn makes perfect sense, but I want to really dig into the mechanism here. How do we get from a simple burn to full-blown cancer? This is where the term Barrett's esophagus always comes up. What is actually happening at a cellular level?
This is, I think, one of the most fascinating and tragic examples of the body trying to help you, and in doing so, failing miserably.
So it's a protective mechanism gone wrong.
Horribly wrong. When that acid keeps hitting the lower esophagus day after day, the body's intelligence system basically says, hey, this isn't working. These squamous tiles we put down are getting burned off constantly. We need to renovate.
It decides to renovate.
It initiates a process called metaplasia, specifically intestinal metaplasia.
So it's replacing the building materials.
It is literally changing the cell type. It rips out the flat, skin-like squamous cells and replaces them with tall, column-shaped cells, the exact kind of cells you find lining your intestines.
And why would it do that? Why intestinal cells?
Because columnar cells are mucus factories. Their whole job is to produce a thick, protective slime barrier. The body's logic is, if we can't stop the acid, let's at least build a wall against it.
So Barrett's esophagus is basically the body trying to waterproof the tunnel.
That is a perfect analogy. It is trying to waterproof the tunnel against an acid flood. And for a while, it kind of works. The symptoms of heartburn might even get a little better because this new lining is tougher against the acid.
But there's a catch.
There's a huge catch. This renovation is unstable. These new intestinal cells are growing in a foreign country, a place they don't belong, and they're under constant inflammatory stress from the acid. They start to grow too fast, they get disorganized, they become hyperproliferative.
And hyperproliferation, that's the gateway to mutation.
And mutation is the gateway to dysplasia, which is the precancerous stage. And dysplasia is the gateway to adenocarcinoma. That is the full cascade of consequences. GERD leads to Barrett's, Barrett's leads to dysplasia, and dysplasia leads to adenocarcinoma. It all starts with reflux.
This has to be why we're seeing such a huge demographic shift then. The source material mentions that while squamous cell is still the leader globally, adenocarcinoma is absolutely exploding in the West.
It tracks perfectly with the obesity epidemic in our Western diet. Central obesity, you're carrying weight around your middle, it increases the pressure inside your abdomen.
Pushing the stomach contents up.
Pushing acid up. High-fat diets delay gastric emptying, so the acid sits in the stomach longer, giving it more opportunity to reflux. So in the U.S., in Europe, where these lifestyle factors are driving severe chronic GERD, we see this massive, massive rise in lower esophageal endocarcinoma.
And meanwhile, in other parts of the world,
In parts of Asia or Africa, where rates of smoking and alcohol consumption might be higher, but obesity rates are lower, squamous cell remains king. It's a fascinating piece of medical geography.
okay, let's shift from the cause to the presentation. The patient finally walks into the clinic. They aren't complaining about histology or metaplasia. They're just saying it's hard to swallow.
Dysphagia, yes.
Yes.
But here is where you have to put on your detective hat. You can't just accept trouble swallowing. You have to ask specifically how the swallowing is failing, because cancer tells a very specific mechanical story.
Mechanical, meaning it's a physical blockage, a plumbing problem.
Exactly. Imagine a tumor growing inside that esophageal pipe. It starts as a small polyp. It's taking up maybe 10% of the lumen, the inside of the pipe. You don't notice it at all. And it grows. It's up 30%, 50%.
Now you'd start to notice it.
Now you notice it. You bite into a big piece of steak or maybe some dry bread. It gets stuck. You feel that pressure in your chest. You have to drink a bunch of water to wash it down, and then you're fine.
So it starts with solids, only solids.
Always solids first. That is the malignancy pattern. But, of course, the tumor doesn't stop growing. It eventually blocks 80%, then 90% of the pipe. And now
even liquids can't get through.
Exactly. Now even soup is difficult. Eventually, you can't even swallow your own saliva.
And it seems so obvious when you lay it out, but if you can't eat solids and then you can't drink liquids, you're going to starve. And that's where the weight loss comes from.
That is the classic textbook malignancy pattern. Progressive dysphagia, starting with solids and moving to liquids, plus unintentional weight loss. But, and this is one of the biggest exam traps and clinical traps, there's another condition that mimics this, but it has a completely different timeline.
Achalasia. I remember this being a classic point of confusion. The mechanism is totally different.
Completely different. Cancer is a blockage. Achalasia is a paralysis.
A paralysis.
Yes. Specifically, it's a failure of the lower esophageal sphincter, the valve at the bottom, to relax. That door at the end of the tube stays shut tight. It's a neuromuscular problem.
So it's not that the pipe is clogged with a tumor, it's that the exit door is jammed shut.
That's the perfect way to think about it. And because it's a nerve failure, specifically, you lose the nerves in the esophageal wall, the myenteric plexus, that coordinate the squeezing motion.
The paracelsus.
Right. The whole esophagus loses its ability to push anything down effectively.
Right.
So what does the patient complain about?
Well, if nothing can get through the door, it wouldn't matter if it's solid or liquid.
Precisely. So the patient will complain of dysphagia for both solids and liquids, often right from the very start of their symptoms.
Ah, that's the tell. So if a patient says, I woke up one day last month and suddenly I couldn't drink a glass of water or eat a piece of toast, that points away from cancer.
It points very strongly toward achalasia. And if you do an X-ray, a barium swallow study, the difference is just night and day. With cancer, you see this irregular, jagged, chewed-up looking narrowing. We call it the rat's tail, or an apple core lesion. It just looks malignant.
And achalasia on that same test.
Achalasia looks smooth. The esophagus above the blockage is usually huge, dilated, and full of old food, and then it tapers down to this perfect, smooth point where the valve is clenched shut. We call that the bird's beak appearance.
Wow. Jagged versus smooth, a rat's tail versus a bird's beak.
Nerve failure versus tumor growth. It's a critical distinction to make. Because, misdiagnosing achalasia as cancer is a terrible mistake. But missing a cancer and calling it achalasia, that's a tragedy.
Absolutely. Okay, let's fast forward. We've done the endoscopy, we found the mass, we've biopsied it, it's confirmed to be cancer. Now we have to talk about staging. This is where I think most people's eyes just glaze over, but there's a real logic here too, isn't there? Specifically with the T stage.
Oh, absolutely. The T stage, the tumor stage in the esophagus, is all about one thing: depth of invasion. How deep has the tumor burrowed into the wall?
And the wall has layers, like an onion.
Exactly. You have the mucosa on the inside, then the submucosa, then a thick muscle layer, the muscularis propria, and then the outer lining. The deeper the tumor goes, the worse the prognosis. But there's a very specific, almost microscopic line in the sand that changes everything for the patient. It's the difference between T1A and T1B.
Okay, now we're really splitting hairs. T1A versus T1B. Why does that tiny difference in depth matter so much?
It matters because of the lymphatics. The lymphatic system is the superhighway for cancer cells to escape and travel around the body.
Spread.
And spread. Now, the mucosal layer, that very top innermost skin of the esophagus, is very unique. It has almost no lymphatic channels. So if the cancer is classified as T1A, meaning it is strictly confined to that mucosal layer, it has an almost 0% chance of having spread to the lymph nodes.
Which means you can treat it locally.
You can treat it very locally. You don't need a massive surgery. You can literally go in with an endoscope, a camera down the throat, you just scrape it out from the inside. It's a procedure called endoscopic mucosal resection. It's incredible. The patient might go home the same day.
But the second it crosses that line into T1B.
The second it touches the submucosa, just below the mucosa, everything changes. The submucosa is incredibly rich in lymphatics. It's a dense network of those highways. Once the tumor hits the submucosa, even just a little bit, the risk of lymph node metastasis skyrockets.
So you can't just scrape it out anymore.
No way. The horse is out of the barn. At that point, you have to assume it is spread, and you have to take the entire esophagus out. You're talking about an esophagectomy. It's a massive, life-altering surgery that involves cutting open the chest and the abdomen.
So a single millimeter of depth. That's
Yeah.
the difference between an outpatient procedure and a major organ resection.
That's the stakes of the T stage. It's everything.
Incredible. All right, let's continue our journey. We're leaving the esophagus, traveling south. We're passing through that gastroesophageal junction, that failed valve, and we are entering the stomach.
And the stomach is a different beast entirely. It's a whole new world. If the esophagus was defined by its geography north versus south, the stomach is defined by the style of the invasion, the tumor's personality, if you will.
And this is where the Loring classification comes in.
The Loring classification. It's a simple but powerful way to think about it. It divides gastric cancer into two main types: intestinal and diffuse.
Let's start with intestinal. This sounds like what I would consider a standard cancer.
It is. Intestinal type gastric cancer behaves, well, predictably. It forms a solid mass, a lump. If you look at it under a microscope, it forms glands trying to mimic intestinal tissue. And it's usually driven by that long-term environmental inflammation we talked about.
Like Helicobacter pylori, the ulcer bacteria.
H. pylori is the #1 culprit worldwide. Chronic infection leads to chronic inflammation, which leads to atrophy of the stomach lining, and eventually that same metaplasia dysplasia carcinoma sequence we saw in the esophagus. It's a slow burn. It usually affects older men. And because it forms a cohesive mass, you can see it pretty easily on a scope.
It plays by the rules, so to speak.
It does. But then there's the diffuse type. And honestly, reading the description of this one, it's the stuff of nightmares. This is the ninja cancer.
It's a very good description. Why a ninja?
Because diffuse type doesn't form a mass. It doesn't stick together. It's an infiltrator. The core problem is a loss of cell-to-cell adhesion. There's a specific protein called E-cadherin that acts like the molecular glue holding your stomach lining cells together in a nice sheet.
The glue that keeps the wall a wall.
Exactly. In diffuse gastric cancer, often because of a specific genetic mutation, that glue is gone. The E-cadherin is defective.
So what happens to the cells? They just float freely?
They detach from each other.
Yeah.
And they invade the stomach wall individually, one by one. They spread like water soaking into a sponge. It's an infiltration, not an invasion by an army. It's a ghost.
And this is what leads to that very specific, very famous cell type the source material emphasized, the Signet ring cell.
This is the visual hallmark of diffuse cancer. It's pathognomonic. Imagine a single one of these cancer cells that has gone rogue. It's still trying to do its job, which is to produce mucin, that stomach slime, but it's not connected to a gland, so it has nowhere to release it.
So the mucin just builds up inside the cell.
A huge globule of it fills the cell cytoplasm, and this glob of mucin pushes the nucleus, the brain of the cell, all the way to the very edge, flattening it against the cell membrane. Under a microscope, it looks exactly like a signet ring, with the nucleus as the crest.
And because millions of these individual cells are just soaking into the wall, they don't form a lump. They make the wall itself wrong.
Right. They create this intense scarring reaction around them, what we call a desmoplastic reaction. The stomach wall gets thicker and thicker and thicker. It becomes rigid. It loses its ability to stretch and expand when you eat. And this leads to a condition called Linitis plastica.
The famous leather bottle stomach.
Exactly. If you were a surgeon and you physically touched this stomach during an operation, it wouldn't feel like a soft, pliable bag. It would feel like a rigid, shrunken leather flask.
And think about the symptoms of that. If your stomach is a rigid leather bottle that can't stretch,
What happens when you try to eat?
you can't put much in there. You'd feel full almost instantly. Early satiety.
That's the #1 red flag. A patient says, I take 2 bites of a sandwich and I feel Thanksgiving full. That should send alarm bells ringing for Linitis plastica. And because there's no lump inside the stomach to see on a barium swallow, and sometimes the mucosal surface looks almost normal on endoscopy, these are notoriously, tragically difficult to diagnose early.
You mentioned a genetic mutation with the E-cadherin. Is this hereditary?
Yes, there's a huge genetic component for a subset of these. If you have a patient, especially a young patient, with a strong family history of gastric cancer, you have to think about testing for mutation in the CDH1 gene. That's the gene that codes for E-cadherin.
And if they have that mutation?
If a patient has this mutation, their lifetime risk of developing diffuse gastric cancer is staggeringly high, something like 70 to 80%. The risk is so high and the cancer is so hard to detect that we often recommend a prophylactic total gastrectomy.
You're saying we take their entire stomach out before they even get cancer?
Yes, often in their early 20s. That's how dangerous and how insidious this particular cancer is.
That is absolutely terrifying. Now, speaking of dangerous spread, gastric cancer is famous for showing up in places that seem, on the surface, completely random. It jumps to the neck, it jumps to the belly button, it even jumps to the ovaries.
This is where we need to stop thinking about just the organ and start thinking about the anatomy of flow, the body's drainage systems. Let's start with the most classic one, Virchow's node, the left supraclavicular node.
We mentioned it right at the top, the third clue. Why the left side? Why not the right? It seems so specific.
It's pure plumbing. The thoracic duct is the main lymphatic highway for the entire lower body. It collects all the lymphatic fluid from your feet, your legs, your gut, your entire abdomen. It's a massive channel.
The interstate of the lymphatic system.
The I-95, exactly. And it travels up through the chest, and it hooks into the big veins to return that fluid to the bloodstream. But it does so almost exclusively on the left side, at the junction of the internal jugular and subclavian veins.
So the left side of the neck is the main off-ramp for all the lymph traffic coming from below the diaphragm.
Precisely. And that little lymph node, sitting right there in that junction, Virchow's node, it acts like the first toll booth at the end of that off-ramp. If stomach cancer cells break off, get into the lymph, and hitch a ride up the thoracic duct, That's where they're going to get stuck first.
So when you feel a hard, enlarged node above the patient's left collarbone, you are literally feeling a traffic jam caused by a tumor in their abdomen.
You are feeling the metastatic deposit.
Yeah.
That makes the old name for it, the seed of the devil, feel pretty appropriate.
It really does. Okay, what about the belly button? The Sister Mary Joseph nodule? What's the pathway for that?
This one is usually a sign of more advanced, widespread disease. It's a sign of peritoneal carcinomatosis. The cancer has broken all the way through the stomach wall and is now spreading like seeds on the peritoneum, the thin, Saranov-like lining of the entire abdominal cavity.
And the umbilicus, the belly button, is a weak point.
It's an embryological remnant. It's a place where things used to connect. It creates a path of least resistance. So the cancer cells track along those peritoneal surfaces, find their way to that weak spot at the umbilicus, and form a hard, palpable nodule that you can feel from the outside.
And then there's the third one, the Krukenberg tumor. This is the one that can really fool the gynecologist, isn't it?
It creates a tremendous amount of confusion. A Krukenberg tumor is a large, solid mass on one or both ovaries. But, and this is the critical part, it is not primary ovarian cancer. It is metastatic gastric cancer.
So how does it get from the stomach all the way down to the ovaries? Is that through the blood, lymph?
It's actually gravity, or more accurately, it's something called transcolonic spread. Imagine those cancer cells, especially the Signet ring cells, flaking off the outer surface of the stomach. They fall into the peritoneal fluid that lubricates your abdominal organs.
And they just float around in there.
They float around like dandelion seeds in the wind. And where do they settle? They drift down into the lowest part of the abdominal cavity, which is the pelvis. And what's in the pelvis? The ovaries. The ovaries are a rich, vascular soil for these cells. They land, they implant, and they grow into massive tumors.
So you could have a woman present with what looks for all the world like primary ovarian cancer, but the real villain is hiding up in her stomach.
Correct. And that's why if you do a biopsy of that ovarian mass and the pathologist sees Signet ring cells, with absolute certainty that it did not start in the ovary, you have to look up. You have to scope the stomach.
That is just a brilliant and terrifying example of why you can't treat organs in isolation. The abdomen is a shared space.
It's a community. And what happens in one neighborhood affects all the others. And that brings us to our final anatomical zone for today. We're leaving the stomach and entering the duodenum and the proximal small bowel.
This always feels like the forgotten territory in GI oncology. The esophagus and stomach get all the headlines. What's actually hiding in the small bowel?
Well, you're right. Primary cancers here are much rarer. The transit time is fast. The immune system is different. There are lots of theories why. But that very rarity makes it a perfect trap for clinicians and students. And the most famous resident of the small bowel is the carcinoid tumor.
Carcinoid tumors. These are the neuroendocrine ones. They're weird. They make hormones.
They do. They often secrete massive amounts of serotonin. And everyone who goes through medical school learns the classic carcinoid syndrome. They can rattle it off. Flushing, diarrhea, and bronchospasm, which is wheezing.
Sounds very memorable triad.
Very memorable. But there is a massive physiological trap buried in that triad that almost everyone misses.
The liver trap, as the outline calls it.
The liver trap, exactly. Let's play this out. Let's say you have a big carcinoma tumor in your small intestine.
Yeah.
It's pumping out serotonin like crazy. Tons of it is getting into the bloodstream. But the patient has no flushing, no diarrhea, no wheezing. Why not?
It has to do with the blood flow from the gut. It all goes to the liver first.
The portal venous system. Every drop of blood from the gut goes straight to the liver before it goes anywhere else in the body. And the liver is the body's primary detox factory. It's packed with an enzyme called monoamine oxidase, or MAO.
And MAO breaks down serotonin.
It breaks it down almost instantly. The liver scrubs the blood clean of serotonin. So even if the tumor's raging in the intestine, the liver protects the rest of the body from its effects.
So the liver effectively masks the syndrome.
It completely masks it. You can have the tumor for years and have no systemic symptoms. The only way you get the flushing and the wheezing and the diarrhea is if that defense mechanism is breached.
And how would it get breached?
Two ways. Either the cancer has spread to the liver itself.
So the metastases inside the liver can dump serotonin directly into the blood leaving the liver.
Exactly. They dump it into the hepatic veins, which drain into the inferior vena cava and go straight to the heart. That bypasses the filter entirely. The serotonin then hits the right side of the heart, causing valve damage, then goes to the lungs, causing wheezing, and then the systemic circulation causing the flushing in the face.
That is such a crucial insight. So if a patient actually presents with carcinoid syndrome with the full-blown flushing and wheezing, It means, by definition, that they already have liver metastasis.
Correct. It implies stage 4 disease right off the bat. The syndrome itself is a sign of metastasis. You cannot have the systemic syndrome from a primary intestinal tumor alone.
Wow. Okay, let's quickly touch on two other key players in this very specific region before I try to synthesize all of this. Ampullary cancer and Zollinger-Ellison syndrome.
Let's hit ampullary first. This is a very specific, very small tumor that arises right at the ampulla of Vater. This is the tiny nipple where the common bile duct and the pancreatic duct join together and enter the duodenum.
It's a tiny piece of anatomical real estate, but it's clearly a critical junction.
It's the traffic circle for all your bile and digestive enzymes. If you put a tumor there, even a tiny one, what's the first thing it's going to block?
The bile duct.
Right. And if you block the bile duct, all that bile backs up into the liver and into the blood. And these patients turn yellow. They get jaundice.
And strangely, that's actually good news, relatively speaking.
It's the best news you can possibly get in that neighborhood. Why? Because a cancer in the head of the pancreas right next door doesn't usually block the bile duct until it's huge and has already spread. But an ampullary cancer blocks it immediately. So these patients turn yellow and come to the doctor when their tumor is still very small.
So they present early, they're still surgical candidates.
They are candidates for the Whipple procedure, the pancreaticoduodenectomy.
I've heard that called the Mount Everest of general surgery.
It is. It's one of the most complex operations we do. You're removing the head of the pancreas, the entire duodenum, the gallbladder, part of the stomach, the bile duct, and then replumbing everything. It carries high risks, but for ampullary cancer, it offers a genuine chance at a cure that is much, much higher than for pancreatic cancer.
And finally, just to round this out, Zollinger-Ellison, this is the too much acid problem taken to the extreme.
We talked about acid refluxing into the esophagus, but if you see a patient who has ulcers everywhere, ulcers in the stomach, multiple ulcers in the duodenum, even ulcers down in the jejunum where they should never be.
That can't just be H. pylori.
No, you have to think about a gastrinoma, a neuroendocrine tumor that is secreting a hormone called gastrin.
And gastrin's job is to tell the stomach to make acid.
It screams at the parietal cells in the stomach to make acid. It's like the gas pedal is stuck to the floor. The stomach just churns out acid 2,4-7. So if you have a patient with terrible refractory ulcers and you've ruled out NSAIDs and you've ruled out H. pylori, you have to check a gastrin level and look for that gastrinoma, which is usually hiding in the pancreas or the duodenum.
Okay. Wow. We have covered a massive amount of ground here. We've gone from the throat all the way to the jejunum. We've talked about renovation, plumbing, ninjas, and traffic jams.
We have indeed.
I want to try and pull all of this together now. I was thinking we could do a quiz, but I feel like that's too simple for the level we're at. Instead, I want to walk through a case. Let's create a hypothetical patient. We can call him Mr. Jones, and let's watch this entire narrative unfold in real time. I want you to apply everything we've just talked about to navigate his journey.
I love it. Let's do it.
All right. Mr. Jones is 55 years old. He's a bit overweight, carries it around his middle. He works a high-stress job, drinks a lot of coffee to get through the day, maybe has a few beers on the weekend to unwind. And for the last, say, 10 years, he's been popping antacids like they're candy for what he calls bad heartburn.
Okay, classic setup. He is the poster child for the Western demographic. The central obesity, the diet, it's all driving chronic GERD. Right now, as we speak, his lower esophagus is bathing in acid. His body, trying to protect itself, has almost certainly undergone that intestinal metaplasia we discussed. He has Barrett's esophagus, but he has no idea.
And in fact, he might even feel a little better, right? Because that new lining is tougher.
That's the silent danger. The renovation has quieted the alarm bells of heartburn.
Yep.
So 5 years pass. He ignores it. He thinks he's fine. Now he's at a restaurant for his anniversary. He's eating a steak. He swallows a bite, and it feels tight. It just sticks for a second in his chest, and then it goes down with a big gulp of water. And there it is. The transition has happened. Somewhere in that patch of Barrett's tissue, a cell has crossed the line. It's become adenocarcinoma. The tumor is now growing into the lumen of the esophagus. Mr. Jones is officially in the solids phase of progressive dysphagia. This is the moment. This is the moment to catch it.
But he's a stubborn guy. He thinks he just ate too fast. He starts chewing his food better. He avoids steak, switches to softer foods like pasta, and he waits another 4, maybe 6 months. Now, even his morning smoothie feels like it's having trouble going down. And he looks in the mirror and notices his belt is 2 notches tighter than it used to be. He's lost 15 pounds without even trying.
Now we are deep in the danger zone. The tumor is no longer just a small polyp. To block liquids, it has to be nearly circumferential. It's blocking the whole tube. Progressive dysphagia to liquids plus unintentional weight loss. He has the two cardinal signs.
He finally goes to the doctor. The doctor does a physical exam. He feels his neck.
And if that doctor is sharp, if they've been paying attention, they're not just feeling for thyroid nodules. They're specifically checking the left supraclavicular fossa. And if they feel a hard, rubbery, fixed node there.
Virchow's node.
Virchow's node. At that moment, we know the cancer has already jumped the tracks. It has metastasized. It's stage high V disease until proven otherwise.
So they order an endoscopy. They put the camera down. They see an ugly ulcerated mass in the lower third of the esophagus. They biopsy it. Pathology comes back, adenocarcinoma.
Everything fits. The story is perfectly consistent with his long history of reflux. Now, the next step is staging. We have to know how advanced it is. We do an endoscopic ultrasound to check the depth, the T stage. We do a PT-CT scan to look for spread elsewhere.
Let's say the EUS shows it's a T3 tumor. It's grown through the muscle wall, but it hasn't invaded adjacent organs like the aorta yet. The PET scan confirms the supraclavicular node is positive, but no disease in the liver or lungs.
Okay, so it's a T3N1M1 disease, locally advanced with a single site of distant metastasis. It's not curable with surgery alone. He needs systemic therapy. The likely path forward would be a combination of chemotherapy and possibly radiation to try and shrink everything down, control the spread, and hopefully convert him into a surgical candidate down the line. But the prognosis is guarded.
A completely different path than if he'd had that scope 10 years ago for his heartburn.
A world of difference. 10 years ago, we would have found Barrett's, maybe with some low-grade dysplasia. We could have ablated it, burned it away with the endoscope, and we'd just be monitoring him.
Okay, let's throw a curveball into the Mr. Jones story. Same guy, 55 years old. But instead of the swallowing issue, he comes in because his belly button feels hard and lumpy.
Okay, everything changes. The esophagus is probably fine. We've just jumped stories. A hard nodule at the umbilicus is a Sister Mary Joseph nodule. That points us directly to the stomach. We'd have to scope his stomach, looking for a primary gastric cancer, probably diffuse type, that has already spread across his peritoneum. The prognosis would be very poor.
And what if he came in not with swallowing problems, not with a belly button lump, but because his face keeps turning beet red and he's been having episodes of wheezing?
Again, different story. We're not in the esophagus or the stomach anymore. That's carcinoid syndrome. That points us to a neuroendocrine tumor, most likely in his small bowel, that has already metastasized to his liver. We'd order a 5-HIAA urine test and a specialized scan, like an scan, to find it.
It is truly amazing how that single initial presenting symptom completely dictates the entire diagnostic investigation. It really is a detective story from start to finish.
It is. And the absolute tragedy of the real Mr. Jones is out there, is that the clues were there a decade ago. The body was screaming. That chronic heartburn was a signal. The body was sending up a flare saying that the foundation is flooding with acid. We have a problem here.
When we get used to the alarms, we just take a pill to turn them off.
We silence the alarm instead of fixing the problem. That's the big takeaway from all of this.
Yeah.
The body gives signals. Heartburn is a signal. Difficulty swallowing, even with just a piece of bread once a month, is a signal. An unexplained drop in weight is a signal. A lump in the neck is a 5-alarm fire. But the timing of when you choose to listen to that signal changes everything.
Absolutely. The difference between a simple endoscopic ablation and a life of chemotherapy is often just 6 months of ignoring what your body's trying to tell you.
That's the hard truth of it.
This has been an absolutely incredible deep dive. We've gone so far beyond just the textbook definitions and really looked at the why behind all of this.
It's the only way to make the knowledge stick. You have to understand the story.
So for everyone listening to this, I think the challenge is next time you see a symptom in a patient, in a textbook, maybe even in yourself, don't just log it as a fact. Connect it. Ask yourself, what is the anatomy here? What is the plumbing doing? What is the mechanism? Why is the body failing in this specific way?
Stay curious. That curiosity saves lives.
Well, next time, we're going to continue our journey south. We've done the upper GI. So for our next deep dive, we are tackling the colon and rectum.
A whole new territory. We'll get into Lynch syndrome, the adenocarcinoma sequence, the different genetic pathways of polyps. It's a completely new world of pattern.
Cannot wait. Until then, keep diving deep.
See you next time.